I assume nothing I said was heard, so I will start over and say thank you so much for the kind invitation and the kind introduction. I'm really pleased to be able to join today. I do wish that I was there in person, but I'm certainly glad to be able to join remotely and hope that the event has been really a wonderful event so far. It certainly sounded like it would be. So today I will just make the note that the folks there are going to be advancing my slides, and personally I find the next slide, please, a little bit disruptive to the flow, so hopefully that's not too disruptive, and hopefully I don't get rambling on like a runaway freight train. And remember to say next slide, please. So thank you so much again for the invitation. Next slide. So just very briefly, in terms of disclosures, these are folks that I do some consulting for, other work for, and or private practice that I own. I will note that none of this work really relates to any of that specifically. All opinions are my own and do not reflect any of the academic institutions or the U.S. Department of Veterans Affairs that I am affiliated with. Next slide, please. To begin, one of my favorite quotes that I think really sums up most of the circumstances here. Reality is the leading cause of stress amongst those in touch with it. Next slide. And the reality really is that we are in a crisis. Next slide. We are facing a mental health crisis, I think, unlike really anything we have dealt with before in modern times. We are facing, next slide, elevated rates of PTSD, depression, anxiety, substance use, and unfortunately suicide. I'm sure many folks saw that recently, I think within the last couple of weeks, or at least last month, there's a report that suicide rates in 2022 elevated again after a couple of years where they kind of leveled out and actually decreased. The thing that is one of many things that is very unfortunate about suicidality especially, but my focus, I will say, really in my work is PTSD and suicidality. And these two these two diagnostic groups, though suicide doesn't actually have a specific diagnostic group, these two symptom sets, though they are very much overlapping with depression, anxiety, substance use, have especially limited treatment options. Really, those options that do exist are relatively ineffective for many people, and also have unfortunately kind of been stagnant for around 20 years. That I would say is kind of the case for much of mental health care, where we have made significant advancements from a pharmacologic perspective. There really hasn't been significant shifts. Next slide. Even with optimal delivery, when we think about the frontline interventions for PTSD and suicidality, even depression, these are SSRIs. These are selective serotonin reuptake inhibitors, or antidepressants, your standard run-of-the-mill antidepressants. And what we know about those medications is that even in the best case scenarios, they are slow acting, meaning that it takes weeks to months for most people to notice really any change at all. And that is, of course, amongst the people who do notice any change or not a worsening of symptoms. There are high rates of non-response or limited response. Many folks who do have some response continue to have symptoms, continue to lead restricted lives. They have a very distressing side effect profile, most notably things like weight loss or weight gain, cognitive impairment, sexual dysfunction, feeling like you just are totally numb to everything, not experiencing the positive or the negative. Of course, because of these things, have very high rates of dropout. And with each new trial that we make, the chances that someone will find improvement actually decrease. Next slide. And I think, that we have to be thinking about how do we actually engage with these problems? How do we find different solutions? Because the solutions that we have been exploring, the solutions that we as the healthcare system, we as modern medicine have been putting out are just not enough. They are not sufficient for so many people struggling with stress and trauma-related concerns, so many people struggling with thoughts of suicide. Next slide. And something that we spend a lot of time looking at in my research program is what we sort of consider this vicious cycle of chronic stress pathology, that we know individuals have individual risk factors, whether those are genetic factors, whether those are, just personal things that have happened to them, belief systems they may hold, any of these things that may contribute to them being more at risk for mental health concerns, including suicidal ideation. We know, of course, there are environmental risk factors and chronic stressors. Sometimes those may be things like marginalization, poverty, limited access to healthcare. Any of these sorts of things, of course, are going to contribute to mental health concerns. And we sort of find ourselves in this experience of having these risk factors, perhaps having these experiences that we know cause significant neurobiological alterations. And perhaps I should back up and say, maybe a lot of folks don't know that. And I think that's something very important about this talk and other talks that include a discussion of neurobiological alterations is, I think there's something very liberating for many people to know that there is something physical that happens. There is something going on in our bodies, in our brains, that happens when we are exposed to stress and trauma, when we are thinking about death, when we are thinking about suicide, any of these things. That is not simply, though it's nothing simple, that is not simply an emotional or cognitive experience. There are also things happening in our brain. One of those being synaptic disconnectivity, which I will say a bit more about in a moment. That then relates to things like emotion dysregulation, cognitive impairment, alterations in sleep, alterations in pain processing, really everything. Synaptic disconnectivity or synaptic connectivity is another term for sort of neuroplasticity. And if we think of neuroplasticity, that's kind of the entire foundation, the entire communication system of our brain is based in these communication pathways, these tiny little roadways that go from one piece of the brain to the other, that go from the brain down into our spinal column and then send messages everywhere. So this is our learning, our memory, our evaluations of experience, our evaluation of sensory data. Any of these things all are based in synaptic connectivity. And we know that the experience of having PTSD or depression or anxiety or suicidal thoughts and behaviors, those experiences in and of themselves are chronic stressors. Living with those symptoms and the impact of those symptoms on ourselves, on our family, on our friends, on our ability to parent, to engage in education, to engage in basic healthcare, to engage in daily activities, to engage in employment, in our relationships, any of these things, those are chronic stressors, which then keeps us going round and round this cycle, sometimes making things worse. Next slide, please. And something that I'm going to talk about today, and all of this I will note is sort of brief, giving a bit of an overview of many things, but is the idea of psychoplastogens, which is kind of a fancy, fun word for what I see as a novel group of medications, a novel group of pharmacologic interventions, and really a paradigm shift in our approach to how we think about mental health and how we think about treating mental health. So SSRIs, the antidepressants, are really based in what is called a monoaminergic hypothesis of depression or stress and trauma-related concerns, where the idea is we need to remedy chemical imbalances in the brain. We need to remedy serotonin, dopamine, norepinephrine, these sorts of things in the brain, and then, ta-da, the symptoms should go away, or should at least lessen. With these psychoplastogens, and when I say psychoplastogens, what that means is medications or pharmacologic compounds that result in a very rapid and robust increase in synaptic connectivity. Very rapidly things are happening in the brain. These include things like ketamine, psilocybin, MDMA, and other things, but I'm really going to focus on ketamine predominantly and say a couple of things about psilocybin, MDMA, and a couple other things. The thing that is really exciting about these interventions is that they move away from that chemical imbalances only approach to looking also at a synaptic kind of approach that really looking at the function of the brain is really important, and how can we perhaps modulate some of those neural circuits? Can we alter the way in which the brain is actually functioning? Next slide. And these interventions are really, dare I say, really cool, because something that's really exciting about them is that in many cases, treatment-resistant patients will respond to them. So those folks who may have tried multiple SSRIs, may have tried multiple therapists, may have tried all of the things, right? All of the things that your healthcare providers can offer you, and still have symptoms. You have been failed. And I am very careful to say, you have been failed. You have been failed by the interventions that healthcare has to offer. You have not failed. I think that is a very important distinction, that the interventions that we as healthcare can offer are not meeting your needs. I think sometimes that message gets a little muddied and honestly can further contribute to people's symptoms. These are rapid acting antidepressants relative to what I said about the SSRIs, which are slow acting. Things like ketamine, psilocybin, MDMA, people report significant shifts in symptoms within hours. Ketamine's peak is 24 hours after the dose. So if we think about struggling with significant suicidal thoughts, depression, PTSD, any of these things, to have the potential of feeling significantly better within 24 hours, rather than 2 to 4 to 6 to 8 weeks, that in and of itself is quite literally life-saving in many instances. These other 3 bullet points I won't really talk about today, but they are exciting in terms of research and better understanding how the brain works, how these medications work, how these medications may work to shift these symptoms and make improvements in things like suicidal ideation. Next slide, please. Going back to my comment earlier, this is another quote that I really like that I think nicely highlights some of the invisibility that can happen in mental health care, that does happen in mental health care. You know, that we may look at someone and say, well, you have all of your limbs, I don't see anything bruised, I don't see anything bleeding, so there must not be anything wrong. And that obviously is entirely not the case. And I think this nicely shows that sometimes it is those invisible wounds, often I think it is those invisible wounds that are more harmful, that are more impactful than the missing limbs or the bruised and bleeding pieces. And I don't at all intend to minimize those other injuries. Those are obviously also very detrimental and impactful, but really highlighting the neurobiological piece and the emotional and cognitive piece that many people struggle with. Next slide, please. Just very briefly, a lot of our work and a lot of many other groups currently are evaluating what are called intrinsic connectivity networks. So kind of these networks of the brain, if we think of them sort of as an interstate system or highway system, if you will, that these are sort of how the different primary bits and pieces of the brain communicate with each other, how information gets from one piece to the next piece. And there are very significant hubs. There are very significant networks that do specific things. There seem to be 3 aspects or 3 networks that seem to be very relevant. One, the central executive network, which really talks about executive functioning, our sort of higher order cognitive processes, things like organization, planning, considering consequences, any of these sorts of things, which sometimes if we think about suicidal ideation, we know that sometimes there may be very careful planning and organization. There also may be very much a lack of that, or a lack of considering consequences, a lot of impulsivity, these kinds of things. The salience network is the part of our brain that tells us what we pay attention to. Where do we focus our attention? What things are salient? Certainly, in depression and PTSD, there is a tendency to perhaps focus more on negatively balanced things, or to focus more on threat detection or things that seem to be threatening. Which again, if that is where our attention is focused, on the negative, on the hopelessness, on the things that continue to make us feel in ways that one may consider, suicide or other things, then it stands to reason that that may exacerbate symptoms. The default mode network is the part of our brain that actually is most active when we are not, most active when we are not cognitively or emotionally engaged in anything. And again, if we think about PTSD, depression, also suicidality, sometimes there's just that dissociative piece where we, kind of check out a little bit. There is certainly a lot of those intrusive thoughts, those ruminations, whether those are based in trauma content in PTSD or just based in that kind of negative content of depression, PTSD, etc. These three networks, there's significant evidence to suggest that in PTSD, depression, suicidality, there can be alterations there. And just as going back to the highway system, if there is a construction project somewhere, if there is an accident somewhere, we know that that causes issues with information getting where we need it to, right? You're going to be late to work. You're going to miss your dinner. You're going to do these things. It's frustrating. The same sort of things happen in the brain. And so what these interventions are looking at a little is, can we wrap up those construction projects? Can we look for alternative routes to get to the same places? Next slide, please. Ketamine is something that seems to very much do that, again, very rapidly and robustly. So this is a slide from animal research. This, I believe, is a mouse model, but we do see the same sorts of things in humans. And this far left side is baseline. This is a neuron in the brain that is that sort of foundation of the synaptic connectivity. And if you look at that, you can see it's kind of robust. There's lots of little nodules coming off of it, lots of little dendrites and spines. And then the middle is what happens when we are exposed to chronic stress. That all kind of shrinks down. It's a bit slimmer. There aren't as many little nodes coming off, not as many opportunities for that information to get out, to go where it needs to. And then when we administer ketamine, the far right panel, you can see that kind of plumps up again. And there's more of those nodes that come out the side. There's more of those repairs that have happened. Those construction projects has wrapped up. Those paths are open now, and there actually may be many new paths. Next slide, please. We saw this, we demonstrated this, or at least what we think is a very good proxy of this, in a study where we looked at healthy controls, individuals with no history of psychiatric concerns, relative to depressed individuals, people with a diagnosis of depression. And what the red and blue indicate are voxels, which are just very little teeny bits of the brain for statistical methods. So looking at neuroimaging data, in healthy controls, we found that, this number of voxels are altered, or kind of what this looks like in healthy individuals. So again, individuals with no history of psychiatric concerns. The blue are showing, where there may be just a little bit of alteration in what those look like from what we might expect. The panel B on the top right shows what the blue is, the kind of the profile of the individuals with depression before ketamine administration. And you can see there is a significant left shift. The individuals with depression do not look the same as the individuals with no history of depression, no history of psychiatric concern. They have significantly more alterations, significantly less global connectivity than the healthy individuals. In panel C on the lower left, this is post-ketamine administration, 24 hours post, in individuals who responded to ketamine. So individuals who reported a significant improvement in symptoms 24 hours after a ketamine dose, just a single 0.5 milligrams per kilogram dose. you can see that shift is now almost identical to the healthy individuals. So that brain connectivity in 24 hours now is looking very, very similar to what the healthy control sample looks like. In panel D, that blue triangle there represents the individuals who did not respond to ketamine, the people who had the ketamine dose but really didn't notice a significant shift in symptoms at all. And you can see that there really wasn't much of a change. So the reason that this is exciting and interesting is that it does suggest there is something very relevant between the connectivity and the actual symptoms or the experience of the symptoms. Next slide, please. Relating to ketamine, we did a study a couple of years ago where we thought that if we give a medication that is suspected to block part of the pathway of ketamine, part of the way that we think ketamine works neurobiologically, that would limit the effects, that would make ketamine's duration of effect shorter. And it really didn't. It actually did exactly the opposite, which was one of those fun and exciting things that happens in research sometimes where we are proven entirely wrong. And I think that's, sometimes we hear so much about the times in research when we are proven exactly right, and that's very helpful. And it is, I think, just as helpful, or perhaps more so, when we are proven wrong. When we discover something that we didn't think would be the case, that gives us a lot of opportunity to explore why that is. And so this was really the case where blocking this part, administering this drug that we know has an effect on part of the ketamine pathway, actually extended the effects, specifically in depressive symptoms, extended the effects by 2 weeks. Next slide, please. But the thing that was really interesting, and this is just a bunch of colored boxes that don't really need to understand, other than to say, the thing that was really interesting is that we looked at this data specifically for the suicide-based questions, the suicidal ideation-based questions. And granted, these are very limited questions, just two items on depression rating scales. But those did not respond the same as the overall depression did. So that there may be something unique, and to me this is not a surprise, but there may be something unique about the way suicidal thoughts and behaviors respond to treatment. There may be something unique about the way that we identify those things neurobiologically and that we treat those things neurobiologically. Next slide, please. I'm not going to spend a lot of time talking about psilocybin or other psychedelic medicines today, but do want to make the point that there are a couple of interventions that are very exciting right now in the FDA pipeline that seem to have similar and or even more robust potential at shifting the synaptic connectivity and really providing an exciting foundation for shifting symptoms and ultimately saving lives. This is a slide that just talks about what we see in psilocybin. This is also an animal model, psilocybin post-dose. 24 hours later, there was a 10% increase in spine size and density. So again, the spine size and density are those pathways, those highways in the brain. And if you think about wherever you happen to live, I know the conference is happening in the LA area. Think about if in 24 hours from now, tomorrow you get up, you go run a couple errands, whatever, if there was 10% more highway around LA, I mean, that would be a whole lot of highway because LA's already got quite a bit of highway. But the thought of, assuming it was done well or that you could adjust those a little, how many more opportunities would there be to get to the places you needed to go? How many more sort of routes and pathways might that allow? Other places to explore, other places to get to where you need. This happened 24 hours later and it lasted for an entire month. So ketamine, if you're not familiar, ketamine is a really exciting intervention The challenge is that after a single dose, most people only experience that significant improvement in symptoms for up to 2 weeks. And I will preface that, of course, to clarify for the people who respond, ketamine and everything else, there is not a one size fits all where this will be the case for everyone. But for the people who respond, generally a single dose will give an improvement in symptoms for between 7 and 14 days. Psilocybin, again, and this is an animal model, this significant shift lasted over a month. Next slide, please. Psilocybin, and I think I have another slide maybe coming up. Psilocybin, this slide is showing sort of a different way of looking at the networks. Sort of each of those colored dots around the outside of the circle are indicating a different connectivity network in the brain, and sort of showing you what it looks like with placebo. But there's, maybe a couple new pathways, and we can expect that. We know that anytime we have a new experience, we take in new information, that we do build new things in the brain. We learn new things, and our brain, has to kind of come up with a place to put that, a place to file it away. On the right side, though, this is what happens with psilocybin. All of these new pathways, all of these new opportunities for information, for learning, for growth, for sort of sorting through things that we may already have learned, whether those are things related to trauma, things related to depression, things related to hopelessness, things related to reasons that one might be considering ending their life, any of these sorts of things, that there's so much opportunity to explore. Next slide, please. I made the comment that there are two medications right now, two drugs that are going through the FDA pipeline. MDMA being one of them. They've just finished the phase 3 trials for that, meaning that they're sort of at the end now of the research period and will be really being considered for FDA approval. The other being psilocybin, which is just starting the phase 3 trials. And what the breakthrough therapy designation from the FDA means is that these are interventions that to date, all of the data suggests that they are as effective or more effective than the interventions that are already FDA approved. So as effective or more effective than SSRIs in this case, that they are thought to be relatively safe, and that there is relatively low abuse potential. Next slide, please. I just said all that. Next slide, please. So very briefly, psilocybin, if you are not familiar, has really evolved with the human race, has been used for millennia across the world, and is the active ingredient in magic mushrooms. Of course, the studies that are happening now are not using the natural mushrooms, not using the natural mushroom product, but are using synthetic versions of these drugs. And psilocybin is interesting in that it also is a serotonergic agent, similar to SSRIs, but also has downstream effects on glutamate, which really, I think, is where we see so much of that rapid shift in the synaptic plasticity. I will make the note that SSRIs do cause some shifts in that connectivity, but again, similar to any shifts in symptoms, that is much, much slower. Next slide, please. MDMA is not a plant-based medicine. It is a synthetic drug, and it was first synthesized in the early 1900s, and causes not only a shift in serotonin, norepinephrine, dopamine, but also causes an increase in oxytocin. And oxytocin is a very interesting neurochemical that is sometimes called the love hormone, or the empathy hormone, these sorts of things. And it's the neurochemical that is present in mothers when they're breastfeeding. It is present when we are having sex, when we are having significant intimate exchanges with another person. Those don't have to be sexual in nature. And so there's a lot of thought that perhaps that empathogen work of oxytocin is a critical piece in the MDMA treatment, because we know that in stress and trauma and suicidal thoughts and behaviors, there is often that isolating, that sense of not belonging, not being loved, not being able to connect with others, not trusting others, not feeling safe with others, sometimes not trusting ourselves or feeling safe with ourselves, not having empathy or compassion for ourselves or others. And I think that's a really important and interesting and exciting piece of MDMA that certainly needs more exploring, but there's a lot of thought that for PTSD, this is a very effective intervention, and that for suicidal thoughts and behaviors, this may be a very effective intervention. Next slide, please. I won't, again, spend a lot of time here, but I would imagine many people have heard of psychedelic-assisted psychotherapy. This is very much in the media right now. If you have not heard of it, I will be very brief here. I think a couple of things, though, that are very worth saying, and I'm mentioning these things, though the talk is kind of focused a bit on ketamine. Many conversations are including ketamine as a psychedelic. There are many arguments as to whether or not that is appropriate. Ketamine is not a psychedelic in the classic sense of the word psychedelic. Ketamine is a drug that does induce an altered state of consciousness, which some people would say falls close enough that we can call it that. At any rate, the important points I would make about psychedelic-assisted therapy are that this is, I think, very importantly, assisted psychotherapy. That the drug, while very important, is a catalyst to helping the psychotherapy piece be more effective. That it really leverages the combined pharmacologic and neurobiological action and the psychological mechanisms, and going back to the synaptic connectivity provides that foundation from which people can reprocess memories, emotions, learning, belief systems. A lot of people will talk about these experiences sort of a rewiring of the brain. I've heard a lot of folks call it sort of a defragging procedure. You know, if you are much of a tech person or a computer person, when we defrag, we kind of clean stuff out and, you know, streamline things. There's a lot of insight, a lot of healing that occurs during these experiences. And they can have very durable effects with continued work. Of course, again, not a miracle cure. These are not, you know, that you go and do the thing sort of spontaneously and ta-da, everything's good. There's a lot of work to be done, and I will say a bit more about that in a moment. Next slide, please. Just very briefly, these are a couple of slides showing the outcomes of psilocybin and MDMA and ketamine. This first one is comparing fluoxetine, which is a very standard SSRI, commonly prescribed, fluoxetine to placebo, and then on the far left, ketamine in the middle, psilocybin on the far right. And what you're seeing is that while all of them are effective, that line, the line in the top shows fluoxetine at 1 week and fluoxetine at 8 weeks. And then you can see that in the middle and far right, ketamine and psilocybin seem to actually continue that shift of symptoms downward, which is really exciting. That we get to the point and then beyond in what we're experiencing with our most standard, widely available antidepressants. Next slide, please. This is just, again, a different slide showing a reduction in depression scores. Next slide, please. This is a study that I, again, will just make very brief note of, that psilocybin versus escitalopram. Escitalopram, again, is just another one of our very widely used SSRIs, antidepressant. And what this study found was that psilocybin and escitalopram kind of were head-to-head, that people were reporting very similar changes. That psilocybin was a tiny bit better, not actually statistically, not actually statistically different than the escitalopram in this particular population with depressive symptoms specifically, but was statistically significantly better in other things. So all of the other things they evaluated. And something I think is very interesting about the discussion that came out of this study was many people saying, oh, well, I mean, if it's not better, then what are we doing? We don't need to study it anymore. To me, this study was a significant win. We know that the antidepressants we have do not work for everyone. We know that there is no one size fits all for any intervention in mental health care or anything else. There is not one thing that is going to work for everyone. So to me, if we have another novel intervention that works just as well as the best that we have to offer, that is really exciting, because this may be something that does work for folks that escitalopram might not, or that Prozac might not, or that, these other interventions might not. And it's all about adding more tools, more interventions to the toolbox. It is not about taking away. It's not about putting these in competition and saying, oh, we need to get rid of this or get rid of that. It's about saying, how many things can we add and what can we find that is effective for the folks who may not respond to these other things. Next slide, please. I will skip this slide, and I think the next one. These are just MDMA findings that found that the MDMA studies for PTSD also had significant symptoms improvement relative to therapy only and relative to antidepressants. Next slide, please. Next slide. Next slide. Sorry. I know that we're short on time. I do want to make the note of some work that I've had the opportunity to collaborate on that is focused on Special Operations Forces veterans, all of whom have gone outside of the US to engage in psychedelic interventions. The reason they have gone outside the US is that currently psilocybin and MDMA specifically are not legal within the US. These are Schedule I drugs, meaning that the DEA says, that these are not safe, they are not appropriate, they are illegal. There are many other drugs that also fall into Schedule I that are also psychedelics. This is the case with this work, ibogaine and DMT. You may have heard of these or may not. Certainly ibogaine has been in the news a lot recently. Kentucky and other states are looking at trying to fund ibogaine research to look at opioid use, opioid misuse specifically, because there's a lot to suggest that may be a very, very useful intervention for folks struggling with opioid misuse. This work, though, we looked at Special Operations Forces veterans who had left the US for this intervention. We know that these individuals are often exposed to significant trauma, have multiple deployments, certainly high rates of stigma around seeking mental health care, very high rates of suicide. Excuse me. Next slide, please. And this was a weekend intervention that they attended. So these are folks who, and as far as I know, pretty much every single case had really exhausted what modern healthcare has to offer, had exhausted what the VA has, exhausted what private healthcare has, had done every SSRI, anti-anxiety meds, had been to therapists, had been to groups, had done inpatient care, had done, all of the things, and still were very symptomatic, still had significantly restricted lives. Went and engaged in these interventions. Again, this is ibogaine and 5-MeO-DMT, excuse me, and had significant improvements overall in the gamut of things, in PTSD, depression, anxiety, cognitive impairment, importantly, suicidal ideation, psychological flexibility. And I put that psychological flexibility here because I think that's such a critical piece, and one that many people talk about with ketamine and other psychedelics, is that, excuse me, that ability to see alternatives, that ability to say, what is happening right here in this moment is not permanent. Whether that is cognitively, emotionally, financially, physically, it doesn't have to be permanent. There are options, there are alternatives. And that's a really important piece. That is a really important piece. Next slide, please. Something else that I think is critically important about these interventions is the things listed here. I think I will let you read those a bit while I say, The top one really strikes me that many people, far over 75%, said that experiencing psychedelic medicine was one of the most meaningful experiences they have had in their life. I have never heard anyone say that about starting Prozac, for example. The reason, though, that I think this slide is so exciting is that often in mental health care, I think absolutely not nearly often enough, but often in healthcare, we are able to save lives. And that is incredibly important. That is incredibly meaningful. That is a huge win. The challenge that I think we face is that often we save lives to the point that people are willing to tolerate existing another day, that they are not actively intending to take their own life or to engage in damaging behaviors or these sorts of things. We get them to that point. And again, that is huge. That means we have opportunity to try again. We have opportunity to work with them, to try more things, to try other things, to get support. However, the thing that I think is exciting about ketamine and psychedelic medicine, psilocybin especially, is that it seems that there is perhaps a foundation there because of the things happening neurobiologically, a foundation from which people who do the work, again, this is not a miracle cure, there is a lot of work to be done, but who do the work, there is a foundation from which people find meaning and purpose and connection with themselves, with others, with loved ones, with nature, with the divine in whatever shape or form that may take for someone, and actually build lives that they truly want to be living. Tolerating existence and truly wanting to live your life are very different conversations, very different experiences. Next slide, please. Next slide. I don't need to note that. I will just say that we also have found very similar findings, very positive findings in shifts in alcohol use, in drug use, and in other sorts of things. I think the thing that I will note, and somehow I missed a slide up above, I didn't miss it, it wasn't there, I missed putting it in, is that we have done some work looking at neurobiological signatures of suicidality. So specifically looking at individuals who do have a history of suicidal thoughts and behaviors relative to those individuals who adamantly deny any of that history. And something that is very fascinating about that work is that neurobiologically, those networks become very isolated within themselves. That all of those lines we saw in that psilocybin graph with everything, kind of connecting to everything else, we see that all kind of isolate away to where one network is kind of only connected with itself or has very limited connections going out. And it's just fascinating, I think, to consider how that mimics what the experience of so many individuals struggling with suicidal thoughts and behaviors is, that they feel so isolated. They feel, even among millions, if you will, considering the brain, if you are in this network of millions, billions, you feel alone, you feel isolated, you feel you don't have support. Which I apologize, I didn't have that slide to show you, but is really interesting. And I will certainly make the plug, since this is AFSP as well. The AFSP funded that work, and hopefully we'll be seeing that come out very soon. I just want to make this note that, I think this work that we're doing, many folks across the world are doing work exploring ways to better treat individuals who are struggling with suicidal thoughts and behaviors, and the myriad of things that contribute to that. I think, of course, a very important point is that no matter how incredible in interventions we have and identify and develop, there are so many societal issues that we must fix and remedy to avoid that chronic stress cycle. That with the best interventions in the world, if we're still sending folks home to be wildly marginalized, experience violence, experience significant poverty, any of these things, we can only expect outcomes to a certain point. Next slide, please. I will just make the note, we can skip this slide. This slide, I know that I know that many folks are desperate. I know that many folks are desperate to find something that works, anything that works to alleviate symptoms. I think things like ketamine and psychedelic medicine are widely talked about in the media, which on the one hand is really exciting. There's awareness being made. On the other hand, I think some of that is potentially dangerous because there is so much hype, and we often hear the stories of these wild transformative experiences people have, and that is true. Some people do have those incredibly transformative positive experiences, and many people don't, or many people have a mediocre experience. So being very cautious for yourself, for your loved ones, if you know people who are talking about these interventions or thinking about these interventions, please know that they are not a one-size-fits-all. Nothing is. They are not appropriate or safe for everyone. So being very cautious about considering, again, for yourself or others, are these safe or not? The set and setting, we didn't talk about that, but making sure that you have appropriate support, you've considered these things, being safe, and just really being prepared for the work, that these, like any other interventions, are not the miracle cure, not the silver bullet that doesn't require work, and that they are difficult interventions because for a myriad of reasons. I know we are short on time. I could go on about these things all day. Next slide, please. If you do have questions, concerns, certainly please feel free to reach out. I am happy to discuss further. Just a note about the Reason for Hope there. That is a advocacy and policy group that I was able to co-found with Brett Waters, who is an attorney, and Lieutenant General Marty Steele, who was a Lieutenant General in the Marines, 35 years, is now retired. But that really focuses on considering thoughtful policy around these interventions. How can we get these interventions out to individuals who desperately need them? How can we reduce regulatory research burden, these kinds of things? So again, thank you so much for your time. Thank you for your interest in this work. Thank you for all of that you are doing to support folks who are struggling, that you are doing to support yourself if you are struggling. I will leave it there. I do see some questions here. Let's see. Question 1, how is this different than having our clients under the influence of Molly or ecstasy? So ecstasy is MDMA. That is really the same drug. One, I would say, ecstasy or Molly is, of course, the recreational term, the street term, any of those things. MDMA is the official pharmacologic name, or abbreviation. That's not the official name, but so MDMA, I think the point that I would make about that is context. So we know that many drugs, ketamine, MDMA, psilocybin, but also Valium, Xanax, any of these drugs that we are often prescribing, people can misuse them. People can and do misuse them. People can use more than prescribed. People can take other people's, any of these things. We know that is the reality. So how is it different from having clients under the influence of Molly or ecstasy? If people are using those recreationally, there is certainly a much higher probability that those individuals are not engaging in the set and setting. So what that means is that they may not have all of the appropriate kind of safety net set up for, one, being screened to know if there are physical health concerns. MDMA, ketamine, psilocybin, all three of those, as well as others that we didn't talk about much, cause increases in heart rate and blood pressure, for example. So if your patient happens to be someone who already has uncontrolled blood pressure, hypertension, or arrhythmia, or these kinds of things, and go engage with one of these interventions, that can become very dangerous very quickly. Also, though, even aside from those concerns, these are difficult interventions. They are going to really rapidly put you in an altered state of consciousness and really rapidly perhaps bring up very distressing memories, very distressing experiences. For many folks, this is deep-seated depressive content, trauma experiences, lots of stress, marginalization, any of these things. If there is not appropriate support, whether that is formal therapeutic, licensed, credentialed support, or at least, very least, support with a friend, family member, trusted individual who can help you and support you through that experience, that's where we know that people have negative experiences with these things. Happy to say more about that. Any reason for synthetic instead of natural form of psilocybin? At this point, really, the reason that people have been using synthetic for clinical trials is that that's what the FDA has been willing to put forward. And the reason for that is that it is much easier to synthesize and know the exact purity of the drug, to know exact quantity of how much is there, any of these things. Of course, with mushrooms, it's not as much an issue of, having these cut with fentanyl or things like that, which we know, of course, is a significant concern in other sorts of drug use. The challenge that with mushrooms is that depending on where these come from, if they were homegrown, if you happen to find them out in the forest, whatever, mushrooms can be dirty, mushrooms can have mold, mushrooms can have any of these things, which one might just make you a little sick or might impact the way that they're working, might impact or influence what the experience is. There is, Arizona just passed legislation, I think $5 million of legislation that will support exploring now the natural form. I think there are a lot of benefits to exploring the natural form. One, most critically, we know that a lot of people are using the natural form. And if we don't know the safety of that, if we don't know if that works differently or the same than the synthetic, then we're missing an incredible opportunity of knowledge, of potential safety, of harm reduction, of any of these kinds of things. So really at this point, the reason for the synthetic is that is what the FDA has approved, because it is easier to really identify exactly what it is. I think also, to be perfectly honest, it is also a capitalist society in which there is money to be made in synthesizing something new. That is also an issue, certainly, that we can't ignore, that some people stand to make money off of new patented drugs and things like this. I don't see other questions. I'm not sure if there are any other questions. All right. Well, I think that's my time. Thank you again so much for the opportunity to join you. I hope something that I said was useful. I hope you enjoy the rest of the afternoon and take good care. Thank you so much.